Well, just as a little bit of a background, I think we've been so focused on this opioid crisis that we have forgotten that these are very brittle people that have significant psychiatric comorbidities, oftentimes depression, anxiety, sleep disorders, substance use disorders. And I think that suicide is really a silent epidemic that has not been focused on because of our over-concern of opioid misuse and abuse. Not that there's not a problem with that, but many people that we have kind of have said classified as unintentional overdoses. I mean, how do we know that? I would say that there's probably a larger percentage than people are aware of that actually end their life due to the suffering from the pain. Risk factors, if you look at the data, anywhere from 15 to 50% of patients with chronic non-cancer pain have daily suicidal thoughts. People with substance use disorders, 40% seeking treatment endorse having suicidal thoughts. If someone has an alcohol use disorder, they're 10 times more likely to take their life than the general population. If they have an injection use disorder, they're 14 times more likely to commit suicide than the general population. So people who have pain and a substance use disorder are particularly vulnerable to committing suicide. Some of the risk factors, there's some pain-specific risk factors. Pain intensity is one. Pain duration is another risk factor. People who tend to catastrophize, and pain patients tend to catastrophize, which is, oh my God, oh my God, oh my God, the pain's gonna kill me, is associated with increased risk of suicide, and sleep disorders. Some of these risk factors you can't change. You can't change the genetic predisposition. You know, you picked your parents poorly. You can't change your gender or your age, but these other factors and risk factors are treatable. Cognitive behavioral therapy for pain catastrophizing could lower the risk for suicide. Most patients with chronic pain, up to 80%, suffer from sleep disorders. If I take a poll of when I do Pain Weekend or Pain Week, and I always ask a large group of physicians how many people feel competent in treating sleep disorders in these patients, maybe one person raises their hands. But we know that when people are sleep deprived, the pain in sleep is reciprocal, so that when you're not sleeping, it actually decreases your pain tolerance and actually increases your pain by causing a pro-inflammatory effect. When you have pain, you don't sleep. Some of the data has shown that sleep disturbance is directly a risk factor for suicide. So we can be more aggressive and more cognizant of treating the catastrophizing, the sleep disorder, and their pain. I think that we're going to see that as we start to take people off of pain medicine, both opioids and non-opiates, that there's going to be an increase in suicide rate. A new study just came out from the VA that showed that people, veterans who were taken off of their opiates, there was a 9% increase in suicide attempts. Again, most patients with chronic pain have lost their jobs, they've lost their family roles, their family, their significant other has to go back to work or to take on more work, they lose their daily activities so that they do feel like a burden on their family immediately and on society as a whole. Most of these patients are extremely isolated also because they've lost this function. So that's a recipe for disaster and a recipe for someone developing, having suicidal thoughts. What kind of drives them to lethality is really they become kind of numb to the pain, and not necessarily the physical pain, but the emotional pain and the thought of actually committing suicide. So they reach this point of no return where they're numb to the concept of life versus death. But these two factors, burdensomeness and isolation, are again two things that can be assessed and addressed. So again, we have to be more aware of these risk factors and not be so obsessed with the opiate part of it, but also the suicide part of it. And I think that every person who takes care of patients with chronic pain should have an action plan. They should actually ask the questions. Physicians don't want to ask two questions to patients. What's your pain level and are you suicidal? Mostly because they don't know what to do with it, particularly primary care doctors who are inundated with seeing more patients, having to document everything on the electronic medical record. But these are patients that are brittle and need to be assessed and monitored assessed and monitored for their risk of suicide. and they should have a very good hotline to local mental health facilities, crisis units, because again, the statistics speak for themselves. In my practice, I tell patients I am not going to take on their case unless they go volunteer. They do something to break this cycle. They can volunteer, talk to their priest, their minister, their rabbi, get involved in the community, attend AA, NA, OA, whatever A, but they need to break that cycle, because I think that's one factor that's going to lead them into this dark place, into this rabbit hole of no return. So I think we can deal with that, again, if we're aware of it. I just don't think that we're that aware of it. I think we're so concerned about other factors, getting our reports done, clicking all the boxes in the EMR, making sure that the patient isn't becoming addicted to the opiates, that we forget, again, about this sort of underlying pathology that's going on. And if we look at opioid misuse and abuse, oftentimes they're self-treating their mood disorders. Opiates are strong anxiolytics, anti-anxiety agents. They have a strong hedonic effect. Before there were antidepressants, they used to use opiates as antidepressants. So sometimes people are taking these opiates not necessarily for pain relief, but for self-treating their anxiety and depression. So again, I think, and PAINWeek's a great opportunity for clinicians to come here and learn the skills of how to assess these patients, how to intervene at their level, how to refer to the right people in their community, so that we can, again, help these people not suffer.